you for joining. My name is Brett. I'm a student here at Texas Women's University. Today we're going to do the hand, forearm, and elbow examination. As you see, I have already drawn some diagrams, some placements on my patient here. I'll point out and address as we go through the examination. It's important to get the timing of pain, whether it's acute or chronic situation, and any other previous history on the patient as you're doing the examination. You want to see if they tried splinting or any other types of treatment. For our symptoms on the hand, we're going to look at the nervous system for any numbness, tinglingness, or any shooting pain. We'll address the blood vessels for temperature, change in the skin color, stiffness, swelling, tendons. We're going to look at any catching or triggering of the fingers here, and any motions that might be aggravated on both sides of the hands here. So what we're going to do first is check for radial and ulnar pulse. The best way is we can check here. I guess I can check there. Or we can check for capillary refills, and that'll be on the we'll blanch the fingertips and the nail bed. Should return within 2 seconds. Also, we can check the brachial pulse near the elbow area. We can feel lymph nodes, epitrochlear lymph nodes. It's also important to do range of motion. What we'll do elbow flexion and extension. And they should be able to touch their thumbs to their elbows. We'll also do forearm rotation, pronation, and supination. And we will also check flexion extension of the digits. You can't see in this photo, but we are flexing and extending at the wrist joint. We are checking to flex the fingers at the distal palmar crease. I've located the palmar crease here, and you want them to bring all their fingertips in to their palmar crease. Check for tendinitis, and when you're checking for tendinitis, you want to check at the elbow and at the wrist or the hand. You want to isolate the tendons that are the problem. So for here, we have the lateral epicondyle. You can't see it in the photo. The lateral epicondyle will be here, and the extensor supinator muscles. So you'll palpate where the lateral epicondyle and extend the wrist. This will elicit pain at the common extensor origin, which is your lateral epicondyle here. Next, we have the medial epicondyle, which you can see here. We'll check, most common name referred is golfer's elbow. So we have the medial epicondyle here, and these are your common flexor tendons, or your flexor muscles. It's where they originate, and they will come up through your carpal tunnel here. This will, as you palpate, if there's pain, then this will most likely be epicondylitis at the medial epicondyle. Next, you have here on the extensor side, the dorsal side of your hand, you have 6 compartments. And beginning here, this is your compartment 1, 2, 3, 4. 5th compartment, and the 6th compartment runs to your little finger. Any one of these tendons running through the compartment can become inflamed. Decurvain tendinosynovitis is the most common, and that is involving the extensor pollis brevis right here, and the adductor pollis longest, which is the first wrist compartment, extensor compartment. It contains your median nerve. Let me get a better shot. Contains your median nerve, your FDS, flexor digitorum superficialis, and your FDP, flexor digitorum profundus. And so to do a Tenniel's test, you would tap along the median nerve here. If it lists, let's see, if there's tingling or numbness, then you have a positive sign. Here in Guillen's canal, the pisiform and hamate, and the volar carpal ligaments. It's where your ulnar nerve, and your artery run through. Penniel's test and the carpal compression test can be performed on the finger, radial side of the little finger, and ulnar side of the ring finger. The median nerve innervates the thumb, the other hand, innervates your thumb, your index, and your middle, whereas the ulnar is the ulnar side of your ring and your pinky here. Next, we're going to do the Watson scaphoid shift test. We're going to check for wrist instability, scaphoid arthritis, and scapholunate instability. I'll place my thumb here on the scaphoid tubercle and go from ulnar deviation to radial deviation. If there's a pop, you've got a scapholunate abnormality. Lixman's ketchup clunk test. You go from radial to ulnar deviation. You feel clunk in the wrist at the midcarpal or lunotriquetral instability. Next, we talk about the dynamic testing. It's the similar concept to static, except you would slide a paperclip along the finger. We'll pretend this is a paperclip. Would slide it along the finger. Again, normal is less than 8 millimeter. Greater than 8 is considered abnormal. For our reflexes, we'll tap the biceps along the anterior distal humerus on the elbow joint. We'll test the brachioradialis, and we'll test the triceps up here. The ulnar nerve runs along the arm, up under the medial epicondyle, through the cubital tunnel, and splits between the flexi carpi ulnaris, which we said was here, and runs through the rest of the arm right here. It can be pinched anywhere between 10 centimeters proximal to the medial epicondyle. Those with cubital tunnel syndrome, symptoms with elbow flexion or Tenniel's tapping. If compression is at the elbow and the patient complains of numbness at the dorsal ulnar part of the forearm and hand. If compression at wrist, numbness at the palmar side or the ulnar side. Those with severe ulnar compression may have problems with their intrinsic muscles, unable to cross the fingers. So I ask the patient to can you bring your thumb over? This one here. There you go. So obviously they would, it would be problematic if they were not able to do that. With carpal tunnel problems, they'll have with their thenar eminence. Here's your thenar eminence, 3 muscles, the abductor pollicis brevis, flexor pollicis brevis, and opponens pollicis. Those are your 3 thenar muscles. Positive Froberg's sign has problems with their pinky, drifting to the side and unable to adduct. There's an adductor digiti minimi here that would enable them to adduct the pinky. So those with problems with the CMC arthritis of the thumb, which would be here, we do a grind thumb test into the trapezium and the carpal bone. Trapezium would be here. Gamekeeper's thumb, problem with the ulnar collateral ligament. They have laxity stabilized in the MC head, and ulnar and radial deviate the thumb to check competency of the ligament. There are 2 flexor muscles responsible for producing flexions of the digits 2 through 5, which are we talked about them earlier, the flexor digitorum superficialis and the flexor digitorum profundus. The FDS will flex at the PIP. So here, can you bring them up? FDS, thank you. Your FDP will flex at the distal IP joint here. Lift them up. That's good. Now we talk about radial nerve palsy. All muscles innervated by the radial nerve, which are the extensors and are not functional, patient would have a wrist drop where they cannot bring their thumb up. Put your elbow down. That would be a wrist drop. And can bring their thumb to extension and cannot cross their thumb over their second digit. We'll test them by doing these 3 movements. We'll isolate the long extensor, extend the MCP joint. They'll have the patient flex their fingers and extend the MCP joint, which will effectively isolate the extensor digitorum communis, and extend their MCP joints slightly through the use of the innervated median and ulnar intrinsic muscles on the flexor side. Therefore, you must isolate the long extensors so that you're not fooled by patients who may have the wrist drop. After radial nerve palsy, we'll talk about ulnar nerve palsy. It's clawing of the little and ring finger. Can you do that? These 2 out. Claw those. There you go. You have hyperextension of the MCP joint here. MCP joint here. And flexion of the IP joint here. For swan neck, you would have hyperextension in the PIP, which would be here, and DIP flexion here. It would be flexed like that. It's hard to demonstrate on camera, the deformity. Finger fractures, look for the nail plane here. If twisted out of plane, fracture or dislocation area on that axis. Flexion deformity for your metacarpal fracture. If you can see all the heads, there's no fracture along the bone. If heads are missing, it's indicative of flexion deformity and a metacarpal or fracture of that finger. And that concludes our examination of the hand, forearm, and elbow. Thank you.